everyone. Welcome to our next session, How Doctors Decide How to Treat Your Cancer. My name is Alex Sanders, and I'm an Oncology Nurse Coordinator at Roswell Park Comprehensive Cancer Center in Buffalo, New York. At most cancer centers, a multidisciplinary clinical team meets regularly to discuss challenging or unusual cases at a meeting called a tumor board. The goal of these meetings is to bring all of the experts into one room together to make recommendations on how to best treat a patient. A tumor board that reviews kidney cancer cases may consist of doctors like medical oncologists, urologists, radiation oncologists, pathologists, and other clinicians like genetic experts, nurses, pharmacists, or clinical trial coordinators. We thought today would be a great opportunity to simulate discussions where our panel will review 3 cases and provide insight into why they would recommend a specific treatment option for that scenario. Hopefully, this gives you a behind-the-scenes look into how doctors collaborate with each other to treat patients with kidney cancer. So let's get started with our first case. Case number 1. Our first case looks at Jack, a 41-year-old male. He had been experiencing back pain for several months, and so he went to his primary care doctor. His PCP thought that Jack might have a herniated disc, so he ordered an x-ray. The x-ray didn't find anything specifically wrong with his back, but it did show a mass on his right kidney. This was an unexpected finding, as Jack hadn't recently experienced any typical signs of kidney cancer, like blood in his urine, abdominal pain, fevers, or any other issues with his kidneys. Jack had an MRI of his abdomen and pelvis done, which showed a 3.5 centimeter mass on his right kidney, which is about the size of a grape or walnut. His doctor ordered a biopsy of the mass. Dr. Eric Singer, a urologic surgeon who treats patients at the Ohio State Comprehensive Cancer Center, and is one of the doctors joining us today. Dr. Singer, can you tell us when a biopsy might be recommended? What can a patient expect during a biopsy of a kidney mass?
Sure, Alexandra. Great to be with you today. So this patient, as you described, has a small renal mass that was incidentally found. So like you mentioned, he was having symptoms unrelated to the kidney mass, had imaging, and then they found this. When we think about a small renal mass, the concern is, could it be a cancer, or is it a benign renal mass, not a cancer? One way to find that out for sure is to pursue a biopsy. The picture that you have up here shows an image-guided percutaneous biopsy. So the radiologist is using an ultrasound machine to take a picture of the kidney and the mass, and then to use a special needle to obtain a small amount of it. And this would let us know, again, is it cancer or not cancer, and potentially provide some additional information to help us figure out which of the many treatment options would be best for Jack.
Thank you. We're also joined by Dr. Jennifer Gordetsky from Vanderbilt University Medical Center, who specializes in urologic pathology. She reviews slides like the ones you're seeing on the screen to make diagnosis. In our scenario with our patient Jack, the biopsy results showed that the mass was a papillary renal cell carcinoma. Dr. Gordetsky, the slide shows what normal kidney tissue looks like under a microscope and what papillary renal cell carcinoma might look like. What features tell you that the image on the left is healthy kidney tissue, and what tells you that the image on the right is cancerous?
So on the left, we see strikingly in the middle of the photo what looks like perhaps a small blob, pink blob that's surrounded by white, and that is a glomerulus. That's the filtration system of the kidney. And then around that, you'll see a bunch of like what looks like little circles with that have white spaces in it, and those are tubules. So what we do is we can look at that little filtration system, the glomerulus, make sure that it doesn't have any abnormalities that we see under the microscope. We can look at the tubules. We can look at the nuclei around those tubules and make sure that they look healthy. We can also look at the vessels. There's a pretty nice looking arteriole in this field. And so we can make sure that that is nice and wide open and doesn't have any sort of what we call arteriosclerosis, or basically where the lumen of that blood vessel is getting smaller, sort of like a straw. You want that straw to be wide open so blood can get to the kidney. If that starts getting closed, then it might be difficult for the kidney to get the blood that it needs. On the right, you can see that you don't see any glomeruli. You don't see any round circles of tubules. There are no normal renal parenchymal structures or renal tissue structures. But what you do see is basically papillary architecture. So when we look at things under the microscope, papillary structures can be sort of cut in two ways. If you think about a hot dog, you can slice that into little round circles that should then not be given to your children. That's like the chokeable circle hot dog. But you can also slice them lengthwise, like they go into a hot dog bug. So depending on how you slice those papillary structures, which kind of like fingers, you'll either see them staring straight at you, right? And they're going to look like little circles, like the tips of your fingers, or you're going to see them standing up like this. And so what we're looking for is fibrovascular cores with malignant cells that are lining the periphery of those cores, and those are papillae. And so that's what we see over here on the right-hand side.
Thank you. Based on the size of the mass on his right kidney, Jack is diagnosed with stage 1 renal cell carcinoma. This slide shows the treatment recommendations made by the National Comprehensive Cancer Center, or NCCN. These guidelines are used by doctors all across the United States to make treatment decisions for their patients. Dr. Singer, what treatment option would you recommend in this case?
Well, I would certainly discuss all of these options with him. So surveillance, thermal ablation, surgery. Given his young age and good health, my recommendation would be to pursue robotic partial nephrectomy so that we'd be able to remove the tumor and spare all of the normal good kidney. I think that would give him excellent functional outcome in terms of preserving his kidney function, as well as excellent oncologic control, making sure that all the cancer is removed and giving him the lowest risk of having cancer come back.
Excellent. Thank you so much. There are a few different approaches a surgeon could use to perform a partial nephrectomy. Can you talk about them, Dr. Singer, and when would you use each of them?
Sure. I think one of the big things to keep in mind is, are we trying to do a partial nephrectomy or a total nephrectomy? The partial nephrectomy, as well as a total nephrectomy, can be done through each of these ways: a conventional open incision, minimally invasive with laparoscopic technique, or with robotics, which is the majority of what my practice is at this point. I think really the fundamental thing that's most important is, are we able to do renal sparing surgery? So can we do a partial nephrectomy, get good cancer control, and then what I advise patients is go to a high volume surgeon at a high volume center and do the surgery the way they do it. So if someone is exceptionally skilled at doing it laparoscopically and they want to do it laparoscopically, that's great. If someone wants to do it robotically, that's fine. Again, there's multiple ways to do it. I think the key is figuring out front what's going to give you the best cancer control, what's going to give you the best functional outcome, and then additionally, what's going to give you the shortest convalescence, fastest recovery time. For me, that typically is robotic surgery. But again, the techniques are very much similar in all of those, where we're trying to prevent bleeding by controlling the blood vessels that lead to the kidney, removing the tumor in its entirety, and then putting the kidney back together, sparing as much of the normal kidney as possible, while doing our best to minimize the risks of complications like bleeding and urinoma or a urine leak from the kidney. But again, high volume surgeons, high volume centers, are certainly, I think, the way to go when seeking a surgical opinion.
Thank you so much. The treatment guidelines also showed that instead of surgery, an active surveillance approach could be used. Dr. Singer, can you explain what active surveillance is and when that may be considered instead of surgery?
Sure. So active surveillance is essentially using X-ray tests to monitor the growth rate of a tumor. The good news is that most small renal masses grow slowly, several millimeters per year. And so many patients are candidates for us to just watch their tumor. And if it gets to be above a certain size, we would say, okay, this may trigger us to do something. With a patient as young as Jack, I'd be a little bit leery about offering active surveillance given his young age, good health, and the size of the tumor. But for many patients, active surveillance is a great option, as many patients have tumors that are unlikely to shorten their lives or cause them any trouble. And we can monitor them carefully, like your schema on the diagram shows here, with regular imaging to monitor for changes or growth. If one of those pre-specified changes happens, then we can always intervene.
Thank you. Sometimes radiation therapy may be recommended for a patient with stage 1 kidney cancer. Dr. Chad Tang, a radiation oncologist at MD Anderson who specializes in treating genitourinary cancers, is with us today. Dr. Tang, can you tell us about the different radiation therapy approaches used to treat kidney cancer? And when would you recommend treating an early stage kidney cancer patient with radiation?
Yes, so thank you for the introduction. The standard treatment approach for most kidney cancers and investigated the most is what we call stereotactic body radiation therapy, which means high doses of radiation therapy delivered with very small margins. And to do that, we use basically a CT scanner, which is built into the radiation machines. There are additional methods that, although not as used in the literature, could offer benefits, such as sparing of the remaining kidney. These include proton therapy or MRI-based radiation treatments, what we call the MRI-LINAC. Generally, radiation therapy, although very promising for the treatment of early stage kidney cancer, doesn't have the same track record as surgery. So usually we would defer to our urologic colleagues about whether the patient is a good candidate for surgery. And if they're not, due to maybe being too old, comorbidities, maybe they only have one kidney, then we will often treat these patients.
Thank you. That concludes our first case. We'll move on to our next case with Betty, a 65-year-old woman. She's had nonspecific abdominal pain or pain that didn't have an obvious cause and discolored urine for about a week. Her doctor ordered a CT scan of her abdomen and pelvis that showed a 6-centimeter mass on her left kidney that extended into the renal vein. A 6-centimeter mass is about the size of an egg. We have Dr. Amy Luckenbach, a urologic surgeon who treats patients at Vanderbilt University Medical Center. Dr. Luckenbach, in this scenario, the patient's tumor was only extending into the renal vein, which is shown in the top left image, but sometimes the tumor can extend past the renal vein. Can you explain what we're seeing in these examples and how this mass would be staged?
Absolutely. Thank you for having me. So you can see in that top left image, the tumor thrombus extends into the renal vein, which is basically a tumor thrombus is a fancy word for the tumor extending into the renal vein. But it can extend into what's called the vena cava, which is the biggest vein in the body, which is shown in image 2 and 3, kind of as you work across the top. And that's really important because when it's extending into the vena cava, especially if it's going to the liver, which you see over there on the top right, we might involve surgeons from other specialties to help us with the surgery, like a transplant surgeon or a vascular surgeon or liver surgeons, and they help remove the entire tumor with us. And that's done different surgeons depending on different locations, but it's usually a multidisciplinary team that does a surgery like this. And then in the last example on the bottom right, you can see the tumor can extend all the way from the kidney up into the heart. And that's a level 4 thrombus. And so for that example, we would actually involve cardiac surgeons in the surgery. And although these things change our surgical planning quite a bit, staging wise, these are still fall under a stage 3 kidney tumor.
Thank you. We're looking again at the treatment recommendations made by NCCN. Dr. Luckenbach, is there any benefit to biopsy the mass before surgery? And for this case, would you recommend a radical or partial nephrectomy?
So with regards to biopsy for a mass of this size, I don't generally biopsy. It's most likely to be renal cell carcinoma, especially with the thrombus. In some patients, if they had tumors on both kidneys, then we might consider biopsying, or something unusual that would make us not want to operate. But in this case, she probably is going to need surgery. And then with regards to the radical nephrectomy versus partial nephrectomy, it's pretty rare to do partial nephrectomies for patients with a kidney tumor that's extending into the renal vein. Again, I would do that only if someone had one kidney or had a good reason for us to do this. In most cases, we would do a radical nephrectomy for a patient like this.
Thank you. So Betty did have a radical nephrectomy and an IVC tumor thrombectomy. Dr. Luckenbach, can you explain more about this surgery?
Absolutely. So this is a surgery that in most locations is done by an open approach. In some locations, they do it robotically. And as Dr. Singer mentioned, you want to go somewhere with a high volume team that does a lot of these in a way that they feel comfortable. And so what we would do is we would first basically free up everything around the kidney. And then once the entire kidney is free, it will be left attached just by this vein and the tumor going into the vein. And you can see on the left, we then clamp the vein in 3 spots: below where the tumor is, above where the tumor is, and we clamp the vein that goes to the other kidney. And that helps protect from both bleeding when we cut open that vein, but also it prevents the tumor from traveling anywhere else during our dissection. Next, after we clamp everything, we cut open the vein and the vena cava, the biggest vein in the body, and we remove the tumor, thrombus, and the kidney all together as one big piece. We then sew the vein shut, which is shown all the way on the right, and we remove all the clamps to make sure that there's no bleeding. And after that, we close and we wake the patient up. And that sounds somewhat simple, but it is fairly complex. And like I mentioned earlier, generally it's done with a multidisciplinary team at a high volume center that does a lot of these.
Thank you. The pathology from the tumor removed during surgery showed that it was clear cell renal cell carcinoma. Dr. Grodetsky, looking at the example slide, how can you tell that this is clear cell RCC?
So again, on the left, we have what is normal renal tissue with the glomerulus looking as beautiful as it did before. On the right, if you compare that to the previous tumor we saw, these are sort of nests and cords of cells with clear cytoplasm. And that is where it got its name, clear cell renal cell carcinoma, from. This is actually the most common subtype of renal cell carcinoma that we see in people. It tends to be more common in men, and it's actually because it's associated with some hereditary tumor syndromes. It's one of the tumors that we know the most about. And based on if we were able to zoom into this picture and just look a little closer at those nuclei, we could then see additional features that might tell us how aggressive this tumor is going to behave. But it's really that beautiful sort of white clearing around the center, the nucleus in the center of the cell, that gives it its name, clear cell renal cell carcinoma. Perfectly clear.
Thank you. The treatment guidelines recommend that for stage 3 kidney cancer, additional treatment after surgery may be recommended. We're joined by Dr. Stephanie Berg, a genitourinary medical oncologist who sees patients at Dana-Farber Cancer Institute. Dr. Berg, can you talk about why some patients may need additional treatment after surgery?
Thank you, Alexandra, and thank you, everyone. I'm learning so much. I think it's really important when we look at our guidelines about identifying the proper patients for adjuvant therapies. We've had a long history in kidney cancer of what we say not significant trials. So in the beginning, there was one medication that we were suggesting called sunitinib, which has actually been moving further down the list. And we can see here, even in the stage 2 and the stage 3 setting, we note that especially the patients enrolled on these adjuvant studies, they are at higher risk for their cancer coming back. So we like to use nomograms as well, which incorporate strategies that we can use to inform our patients, looking at their age, their size of their tumor, their histology, the grade, along with their stage is outlined here. If there's evidence of necrosis, lymph node involvement, sarcomatoid features on their pathology. So we use a lot of these features to kind of personalize each of our patients, especially, and again, in the stage 2 and 3 setting, even in stage 4, where you can actually resect all disease, if they can benefit from further treatment after removal of their cancer. So that is why we have listed here pembrolizumab surveillance, and as well as adjuvant sunitinib.
Thank you. The guidelines recommend that if a patient with clear cell RCC receives adjuvant treatment, they could receive either pembrolizumab or sunitinib. Dr. Berg, can you talk about both drugs and when you would use pembrolizumab and when you would use sunitinib?
Of course. As I mentioned before, in the beginning, we had about 5 trials that were done in the same setting. Granted, different patient populations, but again, at least higher risk disease, at least the stage 3 in the VEGF trials, looking at the use of oral therapy for at least a year. And the only trial that came out positive of those 5 was the S-TRACK trial, which looked at this drug called sunitinib or Sutent. We learned, though, over time that these drugs can be quite toxic to patients, and most experienced a lot of toxicity. So we really had to figure who would benefit the most, who was at high risk, lymph node disease positive, and could really tolerate this therapy, especially when we had no evidence of disease during it. I think this is a struggle we see as medical oncologists for all our adjuvant trials and what we're trying to do, again, prevent cancer from coming back. Most recently, we have 4 trials that we looked at with immunotherapy, or what we say immune checkpoint inhibitors. And the one positive trial that we have seen has come out looking at pembrolizumab or Keytruda, which did have a benefit in patients, again, with higher risk disease. They actually did include patients with stage 2 but higher grade, which was different from sunitinib, which included mostly patients with stage 3 disease. I can say from a medical oncology standpoint, the use of sunitinib has really fallen out of favor for that unfavorable side effect profile that we can see from the oral medication sunitinib, like high blood pressure, rash, fatigue, early satiety, meaning they just get like mouth sores, they just don't feel well, their muscles waste away. So again, we really avoid that as much as possible. We do talk to a lot of patients about using pembrolizumab for that same time period for a year, discuss the trial with them. It was called Keynote 564. And really, making sure that they will benefit from it, that they meet those criteria on the study, discuss the benefits and risks, and the really unique profile of pembrolizumab, which are called immune-related adverse events. And it's actually easier dosing. It's given every 6 weeks. So it's something that is really incorporated in all of our discussions. But again, surveillance is still listed on there. So it's something that we like to see these patients after surgery, after they've healed, and really talk to them about the benefits and risks of these medications.
Thank you. Medications used to treat kidney cancers are not without side effects, like Dr. Berg just mentioned. We have Dr. Julia Stevens, an oncology pharmacy specialist who counsels patients at Beth Israel Deaconess Medical Center, with us. Dr. Stevens, can you review some of the side effects patients may experience with pembrolizumab and the side effects that are different with sunitinib?
Certainly. Thank you for having me. Pembrolizumab is one of our classic immune therapies. It essentially takes the brakes off the immune system, so the immune system can go attack those remaining cancer cells if there's anything remaining. But as the immune system is attacking things, it can also attack some bystanders, and so we can see inflammation in other organs. The ones most commonly affected are things like the intestines. People can get colitis or diarrhea. Patients can experience low thyroid levels, and also the skin reactions and rash are another common one. Really, any organ can be affected. So there are some rare situations where patients may have other organs such as the liver or kidneys, even some rare reports of the heart or nerves being affected. But these are really delayed side effects for most people. Most people do not experience any side effects from immune therapy until at least a couple of weeks into treatment, and they can potentially be prolonged. Fortunately, most immune side effects do respond to steroid treatments, and so certainly that's our backbone of treatment there if you do experience one of these. But some things like the endocrine side effects, the hormone impacts, may be long-lasting. In contrast, side effects to sunitinib or Sutent are a little bit more predictable. The most common side effects there are high blood pressure and diarrhea, although certainly people can experience fatigue, loss of appetite, hand-foot syndrome, so peeling or tenderness in the palms of the hand and soles of the feet, mouth sores. It's a little bit hard to predict who will get what side effect, and really important that we as the team are supporting the patient through these side effects so they don't have to stop treatment due to them. So very different profiles, although there are some things that do overlap, such as diarrhea.
Thank you. And Dr. Tang, would there be any role for radiation for stage 3 RCC?
So having the kidney cancer extend a little bit outside the kidney, and it's not a contraindication for radiation therapy. With regard to this case, where there is involvement of a thrombus, we have treated thrombuses in the past, but unlike surgery, after you treat a thrombus with radiation, there will still be residual thrombus left over. In surgery, you'll get it completely removed. The thrombus may regress after radiation, but it won't be as drastic as after surgery. After the surgery, there probably is not much role for radiation therapy to clean up microscopic disease unless there's a gross lymph node or something residual left over. So those are the only cases where we may consider it.
Thank you. Dr. Berg, would you please provide some information about clinical trials that are looking to add additional options for patients with stage 3 clear cell RCC?
Of course. So this trial we're highlighting here is a large study that is looking at the same criteria as the study I mentioned before, which led to the FDA approval of pembrolizumab, Keynote 564. So this is actually called LIGHTSPARK-022, and this is, again, taking pembrolizumab plus belzutifan versus pembrolizumab plus placebo. So belzutifan is a newer drug. It's a hypoxia-inducible factor inhibitor or HIF inhibitor, and it is approved right now for men and women with von Hippel-Lindau syndrome, and it can also be von Hippel-Lindau-associated kidney cancer. So this is a large study in the United States, and again, something that we're exploring, adding a oral therapy in addition to standard of care that we're saying with immunotherapy for this population. And I want to mention as well that the overall survival analysis, meaning are patients living longer, even though their disease might not be coming back as they might have that benefit, we still don't know if patients are actually living longer by receiving pembrolizumab. And that's a big debate we have in all of our fields about how are we really benefiting patients from these treatments. So again, another discussion to have with your physician deciding to go on adjuvant therapy. And I would encourage all patients, if there's a center, Dana-Farber, we have this trial open, and a lot of our investigators on this call likely have this trial open, to go on clinical trials, discuss that with your physician, and see if it's right for you to get a benefit.
Thank you so much. That wraps up our second case. Our final case follows Larry, a 50-year-old man who has had several symptoms over the last 6 months, including fatigue, night sweats, unintentional weight loss, and right hip pain. His primary care doctor ordered blood work, which showed that his liver function tests were significantly elevated. His PCP also ordered an abdominal ultrasound to look at his liver and an MRI of the pelvis to see what could be causing his hip pain. The ultrasound showed multiple small lesions in his liver and a 10-centimeter mass on his right kidney, which is about the size of a grapefruit. The MRI showed lesions on his right and left femurs. A liver biopsy was ordered of one of the liver masses, and additional scans confirmed the masses seen in the other scans. We have Dr. Eric Yonash, a medical oncologist at MD Anderson who specializes in kidney cancer and VHL disease with us today. Dr. Yonash, why would a liver biopsy be ordered instead of a kidney biopsy? And how will the additional PET CT and bone scans help you treat Larry?
Yeah, great question, Alexandra. So in this individual, we clearly have that mass in the kidney, and that looks like a cancer. And we then have, what looks like metastatic disease in the liver. But for us to know that what's in the liver is actually coming from the kidney, we need to know what cell type these tumors in the liver have. So if you then perform the biopsy in the liver and you see it's clear cell renal cell carcinoma, then you basically have answered the question, what are the metastases and what is the tumor of origin? The other imaging studies that have been done here, PET CTs are not one of the most common studies that we do for renal cell carcinoma. Sometimes they're really helpful, but sometimes they provide us either false positive or false negative, meaning that they basically are crying wolf. They're showing things that are positive when they really aren't, because there are some non-cancer things that can show up positive, or they can be silent. So we typically will use a CT scan with and without contrast initially, and then a CT with contrast later, and then doing some other things like MRIs to complement it.
Thank you. The biopsy of one of the liver masses showed it was chromophobe renal cell carcinoma. Dr. Grodetsky, looking at this example, how can you tell it's chromophobe RCC? And how can you tell that the cancer started in the kidney if the biopsy was done on the liver mass?
Yeah, that's a great question. So it's interesting because what you see on the right-hand side is just it's a lot of pink, and then you see some sort of wrinkled nuclei that maybe have some clearing right around the dark nucleus. So if I had this biopsy in the kidney, I would say, okay, well, those are features of chromophobe renal cell carcinoma. And chromophobe is a less common type of renal cell carcinoma. Maybe we see it in anywhere from 5 to 7% of cases, and it has some pretty classic what we call histologic features, which is what we see under the microscope, just on a hematoxylin and eosin stain slide, which is what we're seeing here. And as I said before, wrinkled nuclei. Sometimes you'll see 2 nuclei in one cell, and then you see a white clearing just around the nucleus. Lots and lots of pink cytoplasm. It's one of the pink tumors of the kidney. But we wouldn't rely on our eyes alone in this diagnosis, especially if it's a liver biopsy, because liver looks pink and can also have wrinkly nuclei and just be totally normal. So we would do some additional studies other than just staining with pink and blue stains. And so that's called immunohistochemical studies is what our go-to is. And it's basically looking at proteins in the cells that are specific to kidney. So you may hear your doctor talking about a PAX8, PAX8. That is a specific marker that says, hey, this is kidney, it's not liver. Chromophobe renal cell carcinomas are positive for cytokeratin 7. So that's something else that we might use and see if it stains for. And then, you know, if you're really concerned, you would also do markers that are specific to liver. And, you know, liver tumors like hepatocellular carcinoma have their own specific sort of antigens and antibodies that react with those. So that's how we would tell. We would look at the slide you have here, but then we would do additional studies to verify that this is in fact coming from the kidney, because quite frankly, you can have liver tumors that metastasize to the kidney, and you could have kidney tumors that metastasize to the liver. So anything can go anywhere. So you have to be sure.
Thank you. Looking at the treatment guidelines for stage 4 or metastatic chromophobe and other non-clear cell RCC cases, Dr. Yonash, what would you recommend for this patient? And why would cabozantinib be a good choice for these patients?
Yeah, interesting question. So what we're looking at here are the systemic therapy recommendations for non-clear cell histologies. Now, bear in mind that so clear cell is clearly the most common. There's about 70% or so of individuals with renal cell carcinoma have that. Then the non-clear cell histologies are things like papillary renal cell carcinoma, chromophobe renal cell carcinoma, and some even rarer histologies. This table is for this sort of grab bag of these other histologies. You can see that clinical trial is the first recommendation here, and that's because we really don't know that much yet about what's best for these various non-clear cell histologies. Cabozantinib is an excellent drug for example, papillary renal cell carcinoma, and for chromophobe renal cell carcinoma, it is an option. Although we could certainly be thinking about things like lenvatinib and everolimus, which is a combination which we kind of in the community see as helpful. And more recently, there was a study that was presented looking at the combination of lenvatinib plus another immune drug, pembrolizumab, which also seems to be helpful.
Thank you. Dr. Stevens, what side effects might patients experience when taking cabozantinib? How could they manage those issues?
So similar to sunitinib, as we discussed earlier, the two most common side effects I see are high blood pressure and diarrhea. I have all my patients check their blood pressures at home so we can catch this early and treat it. You might need blood pressure medications or dose reduction of cabozantinib. For diarrhea, that's something that most people on cabozantinib have to some degree. We pay attention to diet. There are certain high problematic foods that can be diarrhea triggers people on cabo. Things like high fat, high fiber foods, really spicy foods. So we might try to avoid those. Many people will also need some over-the-counter antidiarrheal medicines or prescription antidiarrheal medicines to help with this, either on an as-needed basis or sometimes on a scheduled basis also. I do have my patients also start creams prophylactically or preventatively for that hand-foot syndrome that we talked about with the peeling and tenderness in the palms of the hands and soles of the feet. So really that can be helpful to stay ahead of that, and many patients who use that approach preventatively may not have as many problems with it. For the mouth sores, there are several different mouthwashes available. There's some numbing mouthwashes and some anti-inflammatory mouthwashes that can be helpful if that does develop. But with all these side effects, those I mentioned, also fatigue, loss of appetite, and weight loss, it's good to keep in mind also that a break from the medicine may be warranted. You might need a dose reduction of the medication to make it more tolerable. With a drug like cabozantinib, something else I'm thinking of is the very long half-life. So it takes several days for this medication to leave your system, about 3 weeks for it to be entirely eliminated. So if you do need a hold or dose reduction, it's a good idea to give yourself a break, at least for a couple of weeks, in order to see that improvement. And so reach out early and often, because if you do reach out for these side effects, often there's something we can do to help and make you feel better. The earlier we know, the better.
Thank you for the great tips, Dr. Stevens. Dr. Yonash, are there any current clinical trials that are looking at other treatment options for patients with metastatic chromophobe or other non-clear cell RCC subtypes?
Yeah, great question. So there's a large number of studies out there. I'd like to first highlight the Stellar 304 study that you see here on the bottom of this table. So XL092 is basically a follow-on drug from cabozantinib. It's another targeted drug, and that's being tested with nivolumab, so a checkpoint blocking antibody, with individuals with non-clear cell renal cell carcinoma. So this is a study trying to find better drugs for things like chromophobe renal cell carcinoma. I had mentioned before the study that had been completed looking at lenvatinib and pembrolizumab, where we have data which are interesting. We have here also this study of savolitinib, which is a drug that blocks a particular protein that's upregulated in papillary renal cell carcinoma. That's the MET protein. So this is a study that's looking at savolitinib and durvalumab, which is another immune drug in individuals with papillary renal cell carcinoma, so not chromophobe, but a non-clear cell renal cell carcinoma. And at the top here, we have a study that's basically asking the question of whether it's appropriate for us to remove the kidney prior to initiating therapy, or whether we can wait for that until after initiating treatment. So this is one of these questions that we keep on asking ourselves. Do we take that primary tumor out, or do we start with treatment first?
Thank you. Dr. Tang, the treatment guidelines mentioned additional treatments that may be recommended for these patients. What other additional treatment options could be available for patients with liver mets?
Yes, so there's a group of treatments called metastasis-directed therapies, which, unlike drugs, are going to be anatomically located just to the metastatic site of issue. Now, that doesn't mean we can go about and ablate all sites of disease, especially when there's many of them. But in certain patients, when there's a very few sites of disease, which we call oligometastatic, or in which maybe just one site is misbehaving on the drug therapy like cabozantinib, which we call oligoprogressive, it may make sense to do metastasis-directed therapy and just treat the one or limited number of sites. And sometimes that may benefit patients. These site-directed therapies or metastasis-directed therapies include using interventional radiology-based ablations or radiation therapies, such as stereotactic body radiation therapies or surgical resection. And those are all of many of options, and the anatomy of the site will kind of dictate which are kind of the most appropriate options.
Thank you, Dr. Tang. Well, that completes our 3 cases today. Before we wrap up, any final thoughts or anything important to discuss about these 3 cases?
I guess I want to take a moment to say a little bit about just some of the problems, that we run into with small biopsies, or, in like the slides that we were shown in these cases were gorgeous, and it's lovely when we get perfect histology, but it doesn't always turn out that way. When tumors metastasize, they can, quite frankly, look almost like anything or nothing at all. And sometimes they start forgetting sort of where they came from. So we have specific markers that say, hey, I came from a kidney. And but sometimes something leaves and it goes to the lung and it has lost that marker. It doesn't know it came from the kidney anymore. And it can make diagnosing a metastasis very challenging. There are also tumors, that what is, for example, one of the most common causes or risk factors, I should say, for kidney tumors, like many other cancers, is smoking and tobacco use. Well, you can have someone who has a kidney tumor and a lung mass, and maybe the kidney tumor has gone to the lung. Maybe they have both a lung cancer and a kidney cancer. And there can be overlap in how tumors look from different sites. There can be overlap in how tumors stain and the sort of their what we'll see on immunohistochemical stains. So I think as a pathologist, you always have to exert caution when you're seeing biopsies from metastases, and just make sure you're getting the right diagnosis.
One thing I would like to add to the patients out there is a common refrain we hear when they're coming to the radiation oncology clinic is that the patients will tell us, well, I heard from my doctor that kidney cancer can't be treated with radiation. And that was kind of the understanding maybe 20, 30 years ago, but with newer techniques where we can focus the radiation to higher doses and our ability to be very specific, I think that deserves rethinking. That being said, I would never force a radiation oncologist who is uncomfortable with treating kidney cancer with radiation to do it. But perhaps if you're interested in pursuing that option, there's many of the high volume centers will have radiation oncologists who are experienced with this. So just keep that in mind.
Alexandra, I'd just like to make one comment about our first case with that young man, Jack. One of the things I don't think we touched on was the role of a genetics evaluation for patients to perhaps see, is there a hereditary component? And with his young age of being 41, that's someone who I would consider making a referral to our genetics team. We know from the biopsy that he has cancer. Looking at his scans, he didn't seem to have the phenotype of someone who had a hereditary kidney cancer, because there was just one lesion instead of having bilateral or multifocal disease. But again, it's something that we need to keep in our differential. And so I would just say that for that case, in addition to the robotic partial nephrectomy we spoke about, but a genetics counseling evaluation as well, given his young age at presentation of kidney cancer.
Thank you for bringing up that excellent point.
That is such a good point. And especially we know that certain types of papillary renal cell carcinoma can be hereditary, just like the clear cells. I do want to just say, our understanding and subclassification of renal cell carcinomas has really exploded over the last decade. It was said that, well, papillary renal cell carcinoma is the second most common subtype, and that's true. But that's because it's actually about 6 different types of tumors that got lumped together into one category because they all happen to have papillary structures. So, I think what we all think of as like a classic papillary renal cell carcinoma, which used to be called sort of type 1, those are the ones associated with the MET mutations and whatnot. But then we had this whole other category we called type 2s, and we don't even recommend typing papillaries anymore, because when they did molecular studies, they discovered that all these quote unquote type 2 papillaries were actually a whole host of different types of tumors that just kind of got lumped in together because they looked similar. So it's interesting. How is that going to play a role in clinical trials, right? If it's a clinical trial studying papillary renal cell carcinoma, I don't know. It really might be very variable because you're studying not just one type of tumor. So I think, as I said, I think we know the most about clear cell renal cell carcinomas. We can say, hey, yeah, those have chromosome 3p mutations, and they're well studied and well understood. I think we are really on the cusp of having a true, deeper understanding of the other types of renal cell carcinomas.
I guess the thing I would add to this, and this has been touched on by a number of people here, is how important it is to participate in clinical trials. It might be a little scary. It might feel, sometimes I hear patients say, well, I don't want to be a guinea pig. But these studies go through ethics reviews, and usually they're going to be at least as good as what other treatments or standard treatments would be. If they're randomized, usually the what we call the sort of standard arm would be already very good therapy. So it's usually as good as what's there before, plus maybe something better. It's a bit of a commitment perhaps in terms of time and effort, but it's how we have moved the field forward so amazingly in the last 20 years.
Yeah, I'll just comment on Dr. Yonesh as well that we only highlighted a few of the studies that are running right now, but there are many more, especially in the more advanced setting, in clear cell kidney cancer, other ones in the, I don't know if variant histology we're saying now, or the other terms for the non-clear cell, because it's not just non-clear cell. That's not even a thing. There's papillary, there's chromophobe. Even unclassified isn't really true anymore, right? So I think it's important for all patients when they meet with their team to, if they want to get second opinions, to see if they're interested in a trial, what trials are available. There's great resources on the KCA website to direct patients. So I think it's great that we have this today to chat. So thank you again.
A big thank you to our panelists, Dr. Berg, Dr. Grodetsky, Dr. Yonash, Dr. Luckenbaugh, Dr. Singer, Dr. Stevens, and Dr. Tang. We hope that you found this session interactive and informative, and we hope that you have a better understanding of how doctors and clinical teams make decisions with real-life kidney cancer cases.